He went to school, medical school at the University of Connecticut School of Medicine, and did his residency in internal medicine at Boston University Medical Center and his fellowship at Yale. He's had several titles during his career, which included Director of Resident Education at a clinic in Hartford. He is now chair of the Melanoma and Immunotherapy Measures Steering Group Subcommittee for the American Society of Clinical Oncology. And here at Georgetown in Lombardi, he's a co-leader of the Melanoma Disease Group and a member of the Developmental Therapeutics Program. He's worked a lot with biomarker development and translational research and immunotherapy, and we're so pleased that you can talk with us today, so thank you.
Thank you for the wonderful introduction. Again, thank you for the opportunity to speak to the group here, and this is a topic that's very near and dear to my heart and exciting. We've seen this in development for a number of years, so I'm very excited to talk about it today, and this is personalized cancer vaccines and cellular therapy in solid tumor malignancies. So these are my disclosures. And the objectives—
Does everybody see the screen, Sean? Sorry to interrupt.
Okay, I see one thumbs up.
Okay, very good.
So the objectives for today is to understand the basic principles of cancer immunology, to understand the current status of immunotherapies in solid tumors, and to learn about new approaches to immunotherapy with personalized cancer vaccines and adoptive T-cell transfer in solid tumors malignancy specifically. The topic of immunotherapy is so broad, we could really go in different tangents today. So I will touch on a few more broader topics, but we're going to try to keep things focused on the vaccine and adoptive T-cell transfer stories. So cancer immunology has evolved quite rapidly, and our understanding is quite more complex than it used to be. The story, you can date back many, many years, but I think a lot of us would agree that the colitoxin story, going back to the 1890s, where live and attenuated strep and serratia bacterial strains were injected into tumors, really started the immunotherapy and oncology world off, learning about innate immunity as well as adaptive immunity. And then in the 1950s, we had cytokines being discovered and recombinant versions of them being available for study in the labs. So this field is relatively new, and a lot of it is dating to really only the past century. But now we've had the experience of a lot of research going into this, and we have a general understanding of how our immune system usually will recognize a tumor cell as foreign and try to eliminate it, and we call this the cancer immunity cycle. And this usually starts off with a tumor cell releasing antigens. You can see these little red dots are small antigens or peptides or protein sequences. And these are picked up by cancer antigen presenting cells, typically a dendritic cell that's in the tumor environment. And these dendritic cells will migrate to a draining lymph node basin, as represented here in stage 3. And in the priming and activation phase, these dendritic cells will present the antigen on MHC class molecules to T cells and other immune cells that are in the lymph node structure. And this helps train and activate T cells, both on the helper T cell side, these are CD4, as well as the cytotoxic T cell side, which are CD8. And these T cells then will enter the bloodstream in step number 4 and traffic back to the tumor microenvironment. There's a number of steps for extravasation as it crosses over the endothelial layer of the bloodstream and into the tumor. But once these immune cells are in the tumor, they have TCR sequences that will recognize the antigen that's presented by MHC class molecules on the tumor side. And this interaction, as well as co-stimulatory interactions between a T cell and the tumor cell, will allow the T cell to recognize the tumor cells as foreign and to attempt at killing the cancer cells. This is also an area where the T cells might become tolerant depending on the signals that are received from the cancer cells. And you see in step 7, either the T cells can recognize the tumor as foreign and eliminate it, or there may be tolerance developed where the tumor cells actually escape. So this is what we consider the cancer immune editing process, where we go from immunosurveillance to immunosubversion. And the first steps in this immunosurveillance, you have pre-malignant lesions that are developing, and if the T cell recognition is successful, it will eliminate those lesions, and you'll never know that that person or that organism actually had a malignancy that was on the verge of developing. What can happen is that you have immunoselection. So the T cell response may actually be present, but as that tumor is evolving, some of the tumor cells are recognized and eliminated by the immune system and others are not, and it establishes an equilibrium. And this is what we call immunoselection. In the next step, some of those cells that evaded the immune system have learned to escape, and this is called immunosubversion. So when a patient comes to us and has known metastatic cancer, or even locally advanced cancer, this is where the immune system has failed, unfortunately, and the tumors have found a way to escape and find a way around the immune system response. Now, we've learned that this is happening, and we've actually learned how to manipulate it to overcome this tolerance or this immune subversion that's happening in the tumor T-cell interaction. And as you can see in this revision or adaptation of the cancer immune cycle, we have different ways of intervening to try to enhance an immune response to effectively eliminate a tumor. You can see some of the basics at step 1, where we would add chemotherapy or radiation. We release more antigen. We have vaccines and other ways to stimulate the cancer antigen presenting cells so that it can then go and train T cells and other immune cells in the lymph node. We can help that priming and activation phase with drugs such as anti-CTLA-4 targeted agents, as well as cytokines such as IL-2. And as those cells are trained and activated and start migrating, we can help that along. And that can be with vaccines, with antivascular agents or other homing agents. And then once the T cells are in the tumor microenvironment, we can try to enhance the killing ability of those T cells to eliminate the tumor. We can also bypass that whole mechanism and deliver T cells that will recognize the tumor cell as foreign and try to eliminate that. That's where CAR T-cell therapy comes in, and part of the talk will be on TIL therapy. These are tumor-infiltrating lymphocyte therapy that can bypass a lot of this cycle and actually go right to the tumor killing process. So what I'm going to focus on as we go forward is starting off with the therapeutic strategies that are in the bold red with IL-2, CTLA-4, and PD-1, PD-L1 strategies, but we're then going to circle back to the green, which is the TIL therapy and vaccines. So IL-2, we first identified in 1976 as a cytokine, and it was originally just called a T-cell growth factor. It was noted that you put IL-2 in a sample of peripheral blood in the laboratory, and T-cells grow quite rapidly. It was cloned in '83, and then this made it available for research studies, both in the lab as well as in the clinic, and allowing for clinical trials to emerge. But IL-2 is very complicated. We know it can stimulate T-cell responses. It can make them more proliferative. It can lead to anti-apoptotic steps. It can also make them more aggressive, more cytotoxic. So their killing mechanism, the porphyrin and granzymes that are developed within the T-cell actually can be enhanced. And there are other cytokines that it will release when it's stimulated by IL-2. These T-cells have an IL-2 receptor on them. But at the same time, it can be immune suppressive for various T-cell populations. And we also can see that the other T-cell and other populations that are immune suppressive be upregulated. So IL-2, we know, can be immune stimulating, or it can actually be immune suppressive. And interesting, in the laboratory, if you knock out IL-2 in a mouse, it leads to autoimmune disorders. So it actually does play a very important role in preventing autoimmune disorders, in particular hemolytic anemia and inflammatory bowel disease. But in this setting, we know that it actually can be quite stimulatory for lymphocytes, in particular lymphocytes that can be recognizing tumor cells. So if you take a patient that has, or an animal model that has a tumor, and you take some of the blood or the spleen and you produce a culture in laboratory, and then you put IL-2 in that culture, you can expand lymphocytes that will recognize the tumor as foreign and activate killing mechanisms. These were originally termed lymphokine activated killer cells, or LAK. At the end of the day, these actually are T lymphocytes, CD8 positive effector T cells. And what they found is if you do develop or produce these LAK cells and introduce them back into an animal model with a tumor, as well as stimulate with IL-2, you can cause marked regression in tumors. This is in sarcoma and melanoma models, as well as other tumor types. In this figure over here that dates back to 1985, some of the original experiments, that if you treat with low dose IL-2, the tumors seem to be happy and metastasize. You can see the animals unfortunately had quite a large burden, but as soon as you got to high enough IL-2 levels in your dosing, you could significantly suppress the emergence of metastases in this animal model. So looking at animals that were treated with IL-2 as well as lack cells, this is unfortunately in black and white, which makes it a little more difficult, but it's a sarcoma tumor from the lung. To the left is an animal that was untreated, and you can see these spindle-type cells. This is a sarcoma growing with really no suppression. And if you look off to the right, it's a tumor that's been resected from the lung of an animal model that was treated with IL-2, and these black dots, those are all lymphocytes. So you can see that there's a lymphocyte response in the treated IL-2 mouse model in this experiment. So these studies led to clinical trials pretty quickly, initially starting at the NIH, and I just want to give a shout out to Dr. Atkins, who played a major role in developing this. And I think without some of his contributions, we might not have seen it materialize the way it is. But IL-2 has been investigated in many retrospective and prospective studies using recombinant IL-2. The focus has been on kidney cancer as well as melanoma. Dose ranging has been between 600 to 720,000 international units per kilogram, and it's given as a 15-minute intravenous infusion. And this is in the inpatient setting. We give it every 8 hours. Over 5 consecutive days, and you give 14 to 15 doses. Usually you don't get all the way to 15 doses because there are toxicities that develop. And you go for 1 course, which is 2 rounds of this. Beginning days 1 and 15, you repeat imaging studies of patients if they seem to be benefiting from it. You bring them back and you do it again for up to 3 courses. So they could be treated with a total of 6 rounds of IL-2. But we do see a high rate of toxicities with IL-2. Grade 3 or 4 is considered pretty serious in most people's minds. These can be more generic system-wide issues with chills, nausea, vomiting, diarrhea. You can see temporary suppression of the bone marrow with anemia and low platelets. You also see a vascular leak syndrome where you can either have direct kidney injury or poor perfusion and become oliguric. You can retain fluid and your weight will go up, your blood pressure can go down, you may end up in the ICU. And requiring blood pressure support and respiratory support if you have pulmonary edema. But the death rate in appropriately managed patients from side effects is very low, either 0 to 1%, depending which study you want to quote. And we have established management for this. So this is unfortunately a toxic therapy, but in the right hands can be managed very appropriately, and patients can go through this and recover. And it is a short window of treatment. They don't do this treatment indefinitely. So patients have been willing to go through this, and we have set algorithms, whether it's Riger's or hypotension. For example, we would hold antihypertensive medications, administer IV fluids, start dopamine infusion, and initiate an ICU transfer where needed. In fact, in my prior institution, when I was at Moffitt Cancer Center, we used to have these patients in a step-down bed, and we had protocols to initiate dopamine at low dose. And if they ran into further trouble, we would transfer them to the ICU. So we had very set protocols in place. We also have to be aware of the potential for infection and use prophylactic antibiotics. And line care, you need a good central line. In many cases, a Hickman catheter might be considered just to avoid complications related to it. So at the end of the day, we do see good responses in a subset of patients. So the objective response rate for melanoma is 16%. For kidney cancer, it's 20%. IL-2 probably does have some activity in other tumor types, but was never approved or thoroughly studied in a lot of the other tumors that we treat. What you see here, though, the complete response rate is not very high. For example, in melanoma, it's only 6%. But if you had a complete response, you might be cured of your disease. In long-term follow-up, 60% of those patients with complete response have a very durable or permanent response long-term. unfortunately, it's a smaller set of durable responses with partial response as their best outcome, with only 10% long-term survivor. And in RCC, we see slightly higher numbers, but overall it mirrors this fairly similarly. So we've had IL-2 in trials since the 80s and 90s, and it's been FDA approved and standard of care in many cases. Why has high-dose IL-2 fallen out of favor? And just kind of read through and pause, and hopefully everyone can kind of ponder on these. Is the cost? It is a costly therapy to administer. It's inpatient as opposed to outpatient. It can be a toxic therapy. Most patients, if not all, will have some serious toxicity, but it's transient, and we hope to get patients through it successfully. Logistics, you have to admit the patients. They have to be on a specialized service. You need to have nurses trained to do this, and you have to have the right oversight. Otherwise, patients can have serious or fatal outcomes, so it needs to be managed in a controlled setting. Or is it that we now have better immunotherapy options, that this is not a good starting place for patients? In the past, every patient with renal cell carcinoma and melanoma, we used to offer IL-2, but now we have newer drugs to offer to them as opposed to IL-2 as their starting place. So, as you think through this, I think every center might have a slightly different reason to look at this, but I think the overriding answer is really D, even though they're all true, is that we have immunotherapy options that are more effective and safer than IL-2. So these fall into the immune checkpoint therapies. I think most of us have had either direct or indirect experience with these at this point. The two targets that we focus on are CTLA-4, which is in the priming phase here. This is generally in a lymph node where a T cell will interact with an antigen-presenting cell, and the CTLA-4 B7 interaction causes the T cells to arrest, and they become inactive. So what would have been a normal priming and activation phase for a T cell that then could go out and eliminate a tumor becomes inactivated. So we hope that by blocking that pathway, by interfering with the CTLA-4 molecule on the T cell, that the T cell will then become stimulated, activated, migrate to a tumor microenvironment, and actually be able to eliminate a tumor. And we now have monoclonal antibodies that are highly selective for CTLA-4. The one we use most often is called ipilimumab. On the other side, we have, this is in what we call the effector phase, so this is in the tumor microenvironment, and we have an interaction between the tumor cell of PD-L1 and a receptor on the T cell called PD-1. And this interaction leads to T cell exhaustion. So these T cells have already gone through a priming and activation phase in the periphery, migrated to the tumor microenvironment, and they hopefully can recognize the tumor cells foreign and eliminate the tumor cells, but the response has been dampened. That's the interaction from PD-L1 and PD-1. And this leads to T cell exhaustion. Those T cells lie dormant for the most part in the tumor, and they're not really contributing to any control of the tumor itself. With monoclonal antibodies that directly inhibit either PD-L1 or PD-1, we can block this interaction, and those T cells become reinvigorated and can mount an effective response against the tumor and hopefully clear the tumor. So this mechanism we've known is in place for quite a long time. In fact, the PD-1, PD-L1 interaction in CTLA-4 was the subject of a Nobel Prize with two contributors, one from the US and one from Japan, Jim Allison being the one that we've worked with most closely, and has really revolutionized the way we treat cancer, at least ones that are receptive to immunotherapy. And you can see in this list, this is quite a long list. We have FDA approval for PD-1 and PD-L1 drugs for almost 20 different tumor types. And if you add in CTLA-4, it's even a slightly longer list. We also know that in other tumor types not on this list that these drugs can have activity. So a number of tumors that are we can consider using this therapy for really is a long list and continues to grow. And the other part of this is, even though we've administered these drugs as mono or combination therapy, for example, PD-1 drug alone or PD-1 plus CTLA-4, we have now new combination strategies that are emerging and looking quite promising. For example, we may administer a PD-1 drug with chemotherapy. It may be with an anti-VEGF targeted therapy. In melanoma, we have BRAF targeted therapy, and there's now data for combination with an anti-PD-L1 that led to FDA approval, and this continues to grow. And we are seeing increases in the benefit as we've adapted to new combination strategies. And just to put this in perspective, we do see that long-term survival is clearly improved in a range of tumor types. These are just 3 examples of melanoma, kidney, and non-small cell lung cancer. But if you look at these trials, prospective trials with nivolumab plus ipilimumab and nivolumab, you see in melanoma at the 5-year mark that there's about 1/3 of patients that are progression-free. So those patients potentially may be in a permanent remission or even cured and not need further therapy. And the actual clinical benefit, it might be even higher than 1/3 of patients long-term. It's just not captured here. In kidney cancer, in patients that have intermediate poor risk features, we see almost 1/3 of patients progression-free, starting to get far out. This data is really only at the 30-month mark, but we do expect it to plateau. And then in kidney cancer, we see in subpopulations, whether it's high tumor mutation burden or high PD-L1 expression, that we see really high response rates and progression-free survival looks great, that with these therapies, that there may be 1/3 or half of patients that never need another therapy, that their disease is in durable control or even maybe cured. So the long-term survival clearly is better for patients with these therapies, but there's some that don't respond. We see resistance develop, and this can be either acquired or de novo. So we may administer these drugs and patients fail to have any response, or we may administer these drugs and they have an upfront response, and then unfortunately the immune system finds a way to evade, or sorry, the tumors find a way to evade the immune system, and then they can grow and metastasize, and that strategy no longer is working for the patient. And this can happen for various reasons. In melanoma, we think this happens in at least 1/2 of all patients. So while we've made great strides, there's still at least 50% of patients that need another therapeutic strategy. This can be for extrinsic reasons, so extrinsic to the tumor cell, or it could be intrinsic. For example, if the tumor cell is no longer expressing the right antigen, it might be unrecognizable by the immune system. But what a lot of the focus has been on for immunotherapy development has been an extrinsic resistance. These other immune modulatory steps, if we manipulate them, can we enhance an immune response? And there are drugs now targeting a lot of these markers that are here on the screen, whether it's LAG3, TIM3, 4-1BB, GITR, directly targeting regulatory T-cells or adenosine. And by doing this, we have seen some clinical benefit, but unfortunately, the response rates have not been very high. So it has moved the field forward, I would say, at a small step, and we still are looking for other strategies. And what I think is the important thing is that we take a step back on the therapies that we have currently available or have been developing for a number of years. So would IL-2 be effective in a patient who progresses on anti-PD-1 or PD-L1 therapy? Now we started talking about the mechanism. Clearly these drugs work differently, although it's trying to achieve the same response where T-cell can recognize the tumor as foreign to eliminate it. So, is A correct? They activate T-cell responses via different mechanisms, or is it B? No, the mechanisms are redundant. Do they overlap too much? And giving IL-2 to a patient who failed an anti-PD-1 strategy may not actually have a good immune response. Or is it C, somewhere in between? To me, I think that you could choose either A or C, that we probably are harnessing an immune response that follows similar mechanisms, although the drugs definitely work in different ways. So you could potentially see a good response with interleukin-2, where you did not have that response with an anti-PD-1 drug. And indeed, we do have some data with interleukin-2 showing efficacy in PD-1 refractory tumors. And this data is largely retrospective and including only a relatively small number of patients with metastatic melanoma and kidney cancer, but 57 patients treated with interleukin-2 following anti-PD-1 or PD-L1 therapy. We saw a fairly good response rate of 23 and 24% in both populations. And this was compared to patients that were in a large registry who were treated with interleukin-2 prior to the introduction of anti-PD-1 therapy. So they were able to compare it to historical controls. And what they saw was that the responses were similar. So if you responded in this setting, it could be very durable. And then the survival of patients, which are these two Kaplan-Meier figures below. To the left is kidney, to the right is, to the left is melanoma, to the right is kidney. And you can see that these red curves overlap what is the historical survival of patients with these diseases in the blue. So it does look like there is potentially a role for interleukin-2 in patients post-PD-1. But it really begs the question, is that the right strategy, or do we have to think about it in a different context? And what I'd like to do is shift gears here now towards interleukin-2 in the setting of further strategies. So going back to the 1980s, 1986, it was first published that you can stimulate T cells from the tumor, and their T cells in the tumor are 50 to 100% more active than these lac cells that are being stimulated from the peripheral blood. And these T cells already found their way to the tumor, so they are very selective in recognizing the tumor in the microenvironment there. In preclinical models, that using syngeneic mice, so these are mice that have an intact immune system with a colon tumor that mirrors what we see in colorectal cancer in humans, that using TIL therapy in combination with two other agents, you can have a very robust response. So there were a couple very important findings from this. If you look at the Kaplan-Meier figure below in this animal model, that it looked like to have maximal benefit, which is that top curve with the small triangles, you need to first offer cyclophosphamide. This is a lymphodepleting therapy, so it suppresses the immune system in that model temporarily. You administer TIL therapy, and then you administer the IL-2. And if you do the therapy with all three in that combination, you can potentially eliminate the majority or even eradicate the tumor in a large number of animals. So in the description here, you can see in the figure in black and white, the white spots are tumors that are speckled throughout a mouse that has pulmonary metastasis from this colon cancer. And in the figure to the right is an animal that received the cyclophosphamide, TIL, and IL-2. And the lung looks virtually cleared or significantly improved compared to the untreated control. So early on, 1986, we see mice potentially being cured with this TIL-type therapy, tumor-infiltrating lymphocyte therapy. We know that tumors that harbor TIL actually do have better outcomes, and most tumors have some form of T-cell infiltrate. In melanoma, using it as an example, we see a very strong infiltrate in probably about half of the tumors. This is patient 1 in the figure, where you have CD8 positive T cells, but you also have suppressive mechanisms. You have regulatory T cells, that's FOXP3, you have upregulation of PD-L1 and IDO. And then you do have other patients that have very few cells in that environment, but there are some T cells still there. And historically, regardless of treatment, patients who have tumors that have higher densities of T cells tend to have better outcomes. So we know that these T cells are important. And what we have now learned is that you can grow these T cells in the laboratory and use them for adoptive transfer in patients. And this is a schema of how we do this. So a tumor is excised from a patient. It's then brought to a laboratory, and it's processed in a culture system with interleukin-2. And the T cells that are in that tumor microenvironment are grown. And they normally aliquot these T cells in a large panel, which you see there in that the plate with, I'm not sure how many wells there. And what they're trying to do is expand the T cells, different clones of the T cells with interleukin-2. And once they grow them to a certain threshold, they can then take the patient's tumor and test to see if those T cells recognize the tumor as foreign and try to eliminate it through an assay called an interferon gamma ELISA assay. And when they show that those T cell clones can recognize the tumor as foreign and eliminate it, they will then expand those clones for delivery into the patient. The patient will then be admitted to the hospital or in the outpatient setting. and will be given a non-myeloablative lymphodepleting chemotherapy. Nowadays, this therapy is cyclophosphamide plus fludarabine, and that goes over the course of about a week. And then the TIL therapy, the lymphocytes, are infused into the patient as you would more or less like a bag of platelets. And then after that, interleukin-2 is given to the patient. And that is the whole course of this therapy. So it doesn't go on and on. It's a very defined course, much like a bone marrow transplant is. And by doing this, we bypass a lot of the suppressive mechanisms in the tumor microenvironment. And we know that this works very well in mouse models. And what we've seen, this can work very well in humans as well. The first report of TIL therapy in humans was in 1988. So this has been around quite a long time, coming from Dr. Rosenberg's group at the NIH. And they treated 20 patients with metastatic melanoma, harvesting tumors from various sites using a cyclophosphamide TIL followed by IL-2 regimen. So it didn't quite have what we do currently. And what they found was that in IL-2 naive patients, a response rate of 60%, so quite high. And even in IL-2 refractory patients, 40%. Although these numbers are quite small, at that time they weren't really doing conventional CT scans. So you can see in this chest X-ray, these pulmonary metastases pretty much melted away. But at the same time, this was potentially a toxic therapy. At least half the patients experienced something quite serious for a side effect, including hypotension requiring pressors. So fast forward to where we are in 2000s. There's been quite a number of trials. This has been largely developed at the NIH and then expanded at centers across the US and actually across the world, but has still been considered experimental. And just picking one of the more contemporary trials done at the NCI that was published by Stephanie Goff under Dr. Rosenberg's guidance, this is a randomized trial of melanoma patients using 2 different lymphodepleting regimens where the standard cyclophosphamide fludarabine was administered, and then in the other patients that were randomized to the experimental arm, the addition of total body irradiation was added. This was to further suppress the immune system in hopes that you would have even a more vigorous T-cell response against the tumor. And using the same approach of TIL infusion followed by IL-2 and given at every 8 hours until physiologic tolerance, using just the lymphodepleting regimen, which is NMA, the response rate was 45%, with a complete response rate of 24%. And when they added the total body irradiation, the TBI, that response rate was higher. Looking at the toxicities, this doesn't really cover all the potential toxicities, but we certainly can see high level of grade 3 toxicities, including transfer to the ICU. In this study, they found that the average length of stay, or the median, was 18 days, which in my experience sounds about right for most patients. They found, though, that the overall survival and progression-free survival was the same between the groups. And you can see a plateau in the curve right around 30 to 40%. So that means that this is potentially a very exciting and maybe even curative therapy in a range of patients. And that we don't necessarily need to add the radiation, that just adds to toxicity, and that these patients can have durable control with the standard approach. When I was faculty at Moffitt, we started a TIL program. This was a little before my time that it was initiated, but when I joined the group, I participated in the program. And we saw this work out quite well in a number of patients. We were able to grow TIL in 18 out of 19 subjects. We had an objective response rate of 38%. And we saw very deep and complete responses in patients. And to this day, I know that we still have patients alive because of it. But where does TIL therapy fit into our algorithm for treating patients? Is it limited to just the academic research centers like the NIH due to the complexity of TIL manufacturing? Should it be moved up to frontline therapy? Or is it after progression on an anti-PD-1 drug? What I would think this is now at level C. We have good therapy in the front line, at least currently. And TIL therapy can work, but there's a lot of technical and potential toxicity concerns. So this has a potential role in the post-PD-1 treated patients who are looking for alternative therapy to control their disease. We've been fortunate that this has now undergone commercial development. So this is not limited to just a select group of research centers that have a cell manufacturing plant where they can grow the TIL. the company Iovance now has a manufacturing process in place where they can produce this at a scaled level. And as long as your center can resect the tumor and send it off to the central laboratory, and then on receipt, treat patients with the chemotherapy, TIL, and IL-2, then any center in theory can be a TIL therapy center. So Iovance has now conducted a number of trials. This is C144, and the target population with the TIL therapy was a melanoma population who progressed on anti-PD-1 therapy, and if they harbored a BRAF mutation, if they also had to have received a BRAF targeted therapy. And initially they did not freeze the TIL product after expansion, just to be on the sure side they had the process correct. And then in cohort 2, they moved on to cryopreserved therapy. So basically they produced the TIL therapy and froze it and then sent it when the patient was ready for treatment. And they have the production timeline down to 22 days. So when you harvest the tumor and send it off to them, you can resect the tumor and send it off and expect it back in 22 days. So this is not a very long time where patients are actually off therapy. And then once the product is shipped back to the center, you can coordinate for the lymphodepleting regimen, the administration of the TIL, and then the IL-2, and then the patient is discharged. Looking at this study, as expected, there was a high rate of grade 3 to 4 toxicities. They did have 2 patients, unfortunately, who passed on the study, although it was not necessarily related to treatment. But we do see these being transient. Most of them can be controlled. Some of them are blood counts, such as neutropenia and thrombocytopenia, that do recover but may need support. We do see a rate of hypotension in the grade 3 to 4 range of 10.6% in this study. So some patients will end up getting transferred to the ICU for higher level care. But in this study, you can see that the side effect profile is all in the very beginning of treatment. So if you get patients through this approximate 2 to 3 week process, the side effects are ameliorated and they usually don't recur. There are some patients that do have low grade side effects as you get further out from the TIL dosing, but it's very unusual to see. And the response rate in this setting was 36%. So this is in patients who progressed after anti-PD-1 therapy, who progressed with a BRAF target therapy for metastatic melanoma, and we're still seeing a very exciting response rate of 36% in this waterfall plot. And the median duration of response has not been reached in follow-up, meaning that these patients continue to have a good response. So where does this stand at Georgetown? So we had opened this 144 study. I was the principal investigator, but it was a fast accruing study, and unfortunately it met accrual goals before we were able to enroll the first patient. So we didn't actually treat a patient on 144, even though we were trying to participate. We opened a second Iovance study called 202 that I'm the principal investigator of, which is the same process, but using 2 different, slightly different products that I don't want to get into here, but they are fairly standard TIL approaches. And this is for not just melanoma, but non-small cell lung cancer and head and neck cancer. And this trial is currently active. We enrolled our first patient this past month, and we've already gone through the TIL harvest, the tumor harvest process for producing the TIL therapy. And I just wanted to acknowledge the faculty and other team members here that have been involved and have made this happen. And so Dr. Al-Rafai, our surgical oncologist here, resected a tumor that we identified in soft tissue in the back. You can see that tumor displayed here in the lower left. It's measuring about 1.5 centimeters, which is the size criteria to produce TIL therapy. Mary Sidaway, our pathologist, did an intra-op pathology read to confirm it was melanoma. And then you see off to the right, our team here with Stephanie Wagner, our research nurse, that's me in the center, and Dr. Wensing Kui, who oversees the cell manufacturing facility and actually was involved in the operating room to macro dissect the tumor and process it. We were on 5 North in the hospital and shipping it off overnight to the cell manufacturing facility, which was in Florida. So This patient currently is in the steps where we're waiting for the TIL to grow, and we're going to hopefully bring the patient back in the next few weeks to start the treatment. This would be the first TIL therapy administered at Georgetown. We also know that TIL therapy can work in cervical cancer. In an NIH study, there was a response rate of 28% in cervical cancer, and interestingly, it seemed that the T cells were recognizing the HPV E6 and E7 proteins that are integrated when the HPV is involved in the tumor. And these were associated with response. And Iovance has repeated some of this work and shown a response rate of 44% in cervical cancer. So cervical cancer may be another indication as this moves forward. We have seen TIL therapy being successful in subsets of patients with non-small cell lung cancer, renal cell carcinoma, ovarian cancer, uveal melanoma, a rare form of melanoma where immunotherapy typically hasn't worked, and also it can work in the brain. So we've seen melanoma brain metastases regress with TIL therapy. So this is exciting. We expect that it will be FDA approved in the near future. We also see some interesting future research directions, whether it's doing combination therapies with adding TIL to anti-PD-1 therapy, or using different strategies to enhance TIL as it's delivered and produced. So this is a very evolving field and very exciting. So our future plans at Georgetown is we're going to continue to enroll to the study. We have another TIL therapy study underway going through the regulatory steps with a company called Instill Bio that we hope will open in 2021, or maybe even a little sooner. We'll have to see. Georgetown was selected by Iovance to be the TIL commercial center for the regional area. And this will really be an exciting opportunity for us to be leaders in this field. We are now working on creating infrastructure for the patient management, the contracts, and pharmacy. And hopefully in sometime early 2021 with the FDA approval, we'll be able to start treating patients as standard of care. So I'm going to pause just for a second and switch gears. So this is, TIL therapy is very exciting. Unfortunately, because of the toxicity, you do have to select patients, and it won't be necessarily something that we can offer to every patient that progresses on an anti-PD-1 therapy. So clearly there's other strategies that need to be developed, and TIL therapy probably isn't the right strategy for every patient. For example, if we're looking at adjuvant therapies, you need something that's less toxic. So this is a good segue to cancer therapies that are vaccines. And if you think about cancer vaccines, there's several ways you can approach it. Currently, there's strategies to try to prevent the cancer from developing. So some that are virus-driven, for example, HPV with cervical cancer, anal cancer, and head and neck. Some of this is driven by HPV. So if you vaccinate against HPV, you'll lower the incidence of a number of cancers. But once the cancer has developed, those types of strategies really are not effective. And in the past, we have seen development of vaccination strategies against tumor antigens. And if you can train the immune system to recognize these tumor antigens, perhaps they will actually be able to mount a very successful immune response against the tumor. Unfortunately, this hasn't been very successful. Most of these have been shared antigens on tumor cells that are also present in our other host cells. For example, MART1 and GP100 is present in melanoma, as well as melanocytes that are throughout the body. And there's tolerance that develops. So this hasn't been very successful. We've seen approval of one, what we call dendritic cell vaccine. So you freeze out dendritic cells from the peripheral blood and you expose them to antigens, and then you reinfuse them back into the patient. So this is sort of a ex vivo vaccination strategy for prostate cancer that was approved, but has been fairly controversial because the efficacy hasn't been clear cut. But we now have novel neoantigen and mRNA vaccine approaches that are quite exciting. The pitfalls, though, with the strategies of vaccines, the HLA restrictions, so everyone has different HLA genotypes, and not everyone has the right genotype for different antigens. So a vaccine may not work in one person and work in the next. We cover the poor possible tolerance that can develop. And what really has been the disappointing part is that we haven't clearly shown clinical benefit in patients. That if you look at, for example, this study with GP100 against ipilimumab, the dotted line is the survival of patients that got just GP100, and there was actually inferior survival in melanoma. And when we added it to the ipilimumab, it did not enhance the benefit, the survival of patients. So we have really not seen major benefit with vaccines thus far, but there's been a few exceptions. This is one of them where it was administered with IL-2, and it did look like there was at least a trend of improved survival when the vaccine was added to interleukin-2. We've shifted our strategy slightly in two ways. One is looking at mutations. So we know that tumors develop quite a range of somatic mutations. And these are what we consider neoantigens. So the mutation produces a protein that's then recognized as non-self by the host immune system. And there are some tumor types that have a high number of formed neoantigens in this green box. And you can look at them, melanoma, lung cancer, esophageal. These are ones where immunotherapy tends to work very well. We also know that T-cell activity in a range of tumors is higher, or measured by cytolytic activity, as you have more mutations, or if you do a mathematical calculation, if there's a high number of predicted antigens, or mutations use predicted HLA binding peptides. So these would be neoantigens. And to take this one step further, if you look at patients that are treated with various immune therapy strategies, with anti-CTLA-4 melanoma, the higher mutational load or the higher neoantigen load, the greater the clinical benefit. You can see that in the green bars off to the left. And patients with non-small cell lung cancer, those that have a higher non-synonymous tumor mutation burden have greater progression-free survival. And then if you do the mathematical interpretation of the mutations, and the algorithm will give a neoantigen burden, you can see those patients with non-small cell lung cancer treated with anti-PD-1 have greater progression-free survival. So it's really telling us that these neoepitopes, these neoantigens, are what the immune system might recognize best. So we now have a pipeline, a system where you can actually produce a neoantigen vaccine. So you take a tumor, you take the patient's blood, and you compare the genetics between the two using next generation sequencing. You need a high workflow computerized system where you can then identify the difference in the sequences that are unique to the tumor, and those that would produce a short peptide or an antigen that epitope would be novel, that the immune system should recognize as foreign. And then in the laboratory manufacturing process, you can produce that vaccine that's on a patient-by-patient basis. And you can then administer that vaccine that's personalized to that individual patient. So when you do treat patients with this personalized neoantigen vaccine, it can stimulate an immune response at various steps. In this diagram, you can see here it's helping with the T-cell trafficking step that eventually will then go to the tumor and allow for better T-cell recognition and tumor killing. But it also can affect the process in earlier steps, including in the activation and priming phase in a draining lymph node. What we've seen now with some early development published in 2017 and 2018, a peptide vaccine platform. So this is protein vaccines using 20 predicted personal tumor antigens in melanoma, that they were able to generate T-cell responses against those neoantigens. And this was in patients that were resected, high risk for recurrence. They saw that 4 of 6 of these very high-risk patients did not have recurrence after 25 months. So this may have actually prevented recurrence in those 4 patients, although it's not been proven in a randomized study. Where we've also seen is in glioblastoma, where immunotherapy has not worked so far, is that if you use that same approach, that you can generate T-cell responses against those glioblastoma neoantigens. Unfortunately, it didn't produce any objective responses in all patients progressed in that study, but they were able to show that those T-cells made their way to the tumor microenvironment, and at least the patients that were not on steroids. So that's the first step. Now it actually leads the way to how you enhance the immune system further to allow for better tumor killing with those T-cells. So this is really paving the way for the next generation of vaccines. We have a range of vaccines in development. The original versions were synthetic peptides, and we still use them for viruses as well as other strategies, and including in oncology. But where we've seen some of the major developments is the mRNA vaccines. And you might have heard of sort of the new generation that's being developed for the COVID-19 response. So some of this is mRNA development. And there are definitely other ways to vaccinate patients using different strategies, whether it's DNA plasmids or viral vectors. But looking at the mRNA vaccines, so the sequences are constructed in an mRNA transcript. So these are processed, ready to go and be translated. But mRNA that's not protected and injected into a human gets degraded very quickly. So it needs to be packaged in a particle that prevents it from being degraded. So we now use these lipid nanoparticles that protect it. And what ends up happening is that these particles will then fuse with the surface of antigen-presenting cells. You can inject it either subcutaneously in a patient or intravenous, and they eventually do make their way to a dendritic cell where there's fusion and endocytosis. These mRNA transcripts then utilize the antigen-presenting cells machinery to produce the peptides, the proteins. And you can see here off to the right that the antigens are then expressed in MHC complexes on the dendritic cells that are peptide sequences synonymous with what's on the tumor. So these are tumor antigens, and that leads to steps to training the immune system. You also have sort of a generic response when the RNA is processed in these dendritic cells that leads to an innate immunity that also can be effective in eliminating tumors. And you can see that happening through TLR signaling 3, 7, and 8 and secretion of interferons. But it also can assist in the immune response in other ways, such as dendritic cell maturation. One study that I think is exciting that we've seen is the Lipo-MERIT study. It's a vaccine study in patients with anti-PD-1 refractory melanoma. These are 4 shared antigens, so these are not neoantigens. And the product that was produced was BNT111, and it was administered by itself intravenously or with an anti-PD-1 drug. And they saw responses in patients with the vaccine alone in about 12% of patients. And they also saw a higher objective response rate when it was administered with an anti-PD-1 drug. You can see this waterfall plot. There's clearly a reduction in tumor burden in a good number of patients, about a third to a half of patients. So clearly there's activity of this therapeutic strategy. And furthermore, this Nature paper did a great job describing how the immune system is activated at various steps and trained to recognize these sequences, these antigens. We have seen results of several neoantigen studies using vaccines, mRNA vaccines. There was one that was published at AACR. We actually have been involved in this study where they used an mRNA vaccine with up to 20 neoantigens with an anti-PD-L1 drug or alone. And unfortunately, the response rates were fairly low with this strategy, 4% with monotherapy and 8% with combination. But within that, there clearly are patients that benefit from it. And you can see that you're training the T cells, that the neoantigen T cell specific response was 87% in the monotherapy study and 73% in the combination study. So it's really a matter of time to select patients and how to enhance that response, and then we'll start seeing even higher response rates. We do have a study that is exciting, I think, at Georgetown, at least from my perspective, with an mRNA personalized cancer vaccine. This is with Moderna and Merck called Keynote 942 in resected patients. It's a randomized control study of pembrolizumab versus pembrolizumab plus vaccine. We've enrolled a number of patients on this, and this is to prevent a recurrence in high-risk patients. And this is where I think the niche really will be most effective for these vaccine strategies. And it's very exciting to be involved in this work. So with that, I'm going to conclude. Some of the summary here is that anti-PD-1 therapies are highly effective in a range of solid tumor types. But unfortunately, 50% or more of tumors will be refractory to anti-PD-1 regimens. And this will be upfront, de novo, or they'll acquire resistance. So we clearly need new strategies. And there's a lot of development in different directions. But one of those directions that I think is here and is showing very promising results is TIL therapy. And we've seen the highest objective response rate to date for any immuno-oncology strategy in anti-PD-1 refractory patients. So we have not seen with any of the other trials a response rate that's been breaking 30% in multiple studies. So this, I hope, will be FDA approved in the near future and we'll have available at Georgetown. And then the next generation vaccines clearly are showing benefit, but it's in a select number of patients. We're waiting for further results, and we clearly need biomarkers to select those patients and probably strategies to further enhance the immune response. So with that, I'm going to wrap up and thank you everyone for the opportunity to present and your attention for this really exciting topic in oncology.